and community wellness. We are continuously growing, learning and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every PIN code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every PIN code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every PIN code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every pin code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every pin code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every pin code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa. And we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every PIN code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every pin code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus.
Okay, so just allow me the 30 seconds. Okay, so ma'am, it's 3, 2, 1. We are live to the attendance, ma'am. Over to you.
Good evening to all. I am Dr. Komal Madgaonkar from Medical Team JB Pharma. Welcome you all for the today's National Lead HF National Symposia, where we get the opportunity to listen from all the national cardiology experts on the advancement of heart failure. This is an initiative in collaboration with JB Pharma. To begin with, I'll start with the agenda of today's meeting. First, for 2 minutes, there is a context setting by our esteemed moderator, Dr. Haigreve Rao sir, followed by there is a first talk for 15 minutes on Best of ESC HFA Congress by Dr. Rahul Gupta sir, followed by there is a next 15 minutes talk on the clinical utility of GLS in heart failure by our next speaker, Dr. Rakesh Gopal sir. After these 2 talks, we have an expert panel discussions where all the national Indian experts will share their views on this topic. So with this, I'll introduce our today's all faculties. Our esteemed moderator, we have Dr. B. Haigreve Rao sir. Sir is a senior consultant cardiologist and electrophysiologist from KIMS Hospital, Hyderabad. Our esteemed speaker speakers, we have Dr. Rahul Gupta, sir, a senior interventional cardiologist from Apollo Hospital, Navi Mumbai. Our second esteemed speaker, we have Dr. Rakesh P. Gopal, sir, is a senior interventional cardiologist from Apollo Hospital, Chennai. The expert national panelists tonight, we have Dr. Jabbir Abdul Kuti, sir, Director of Cardiovascular Clinical Research from DCU Hospital, Kochi. Dr. Satyanarayan Rautri, sir, a Senior Cardiologist, HOD Cardiology, SCB Medical College, Cuttack. And Dr. Nishant Taggi, sir, a Senior Consultant Cardiologist from Max Super Specialty Hospital, Delhi. So welcome all the esteemed panelists for the meeting. Now I request our tonight esteemed moderator, Dr. Haigirev Rao, sir, to start the session. Sir will set the context for the meeting and then we will start the meeting. I request Dr. Haigirev Rao, sir, to please start the meet, sir. We're just waiting for 2 minutes. Sir will join. Yes, sir. Please start the meet, sir. Hand over to you, Dr. Haigirev Rao, sir.
Am I audible, Komal?
Yes, sir. Please go ahead, please.
Yeah.
Yeah.
Some internet. Anyway, I'll start off straight away so that you can. Yeah. Welcome, everybody. And today is the evening symposium of lead heart failure brought in by the JB Pharma. And I am thankful for being the moderator to a group of very esteemed speakers and panelists. And I'll try to moderate it to the best of excellence of in terms of time as well as for the content. So we have two speakers, as Komal has said. There would be questions only after, discussion questions after the both the talks. So, and Dr. Rahul Gupta would be the first speaker on the EHE highlights, and followed by Rakesh. The main objectives of this program are to give a summary of the highlights of the European Heart Failure Meeting 2025 at Belgrade, and also give a introduction to the GLS assessment of LV function. And then we'll go on to see one of the studies on sacubitril valsartan using this parameter. Over to Dr. Rahul for your first talk.
So thank you for the kind introduction, and I think we'll just start because it's always interesting to learn new things and new guidelines and the new, the information which is available through these meetings and registries. I hope I am audible and the slides are seen.
Yes, sir.
Yeah, loud and clear.
Yes, thank you. So I will be discussing about the latest insights from the ESC Heart Failure 2025, and this which was conducted from 17th to 20th May. So it's fresh from the oven, or you can say. So this annual congress of the Heart Failure Association of the ESC, it covered all the aspects of heart failure, including prevention, diagnosis, treatment, imaging, electrophysiology, and interventional cardiology, with participation from experts across all continents, focused on interactivity through over 80 sessions featuring clinical cases, how-to guidance, and hands-on learning experience, and featured the latest clinical trials and registry results in late-breaking science sessions. So let's explore the insight from some of the important trials at ESCHF 2025. We will discuss about these topics like guideline-directed medical therapy. Is it good to have as fast as possible? Dispelling the myth, are HFrEF patients ever stable? So we'll look into it. What is the insight? Then titration of the sacubitril valsartan in acute heart failure. Trends in angiotensin receptor neprilysin prescribing across multi-center, multi-ethnic heart failure population. So what is the trend? How many people get prescribed? all those things which will give us an insight as to what happens. Arni concurrent HFrEF and kidney failure on replacement therapy. Somebody CKD on a dialysis. Can we give Arni in these patients? What is the result? Additional value of Arni in fusion pacing CRT. Then sacubitril valsartan quality of life assessed using the EQ 5D3L questionnaire level, some score. So to see whether what happens when we give what happens to the quality of life. Then we'll go into the dapagliflozin for HFrEF, early experience of treatment adherence and impact on patient-reported outcomes in evolution heart failure. New and emerging therapy for HFpEF. I think HFpEF is something which is growing more than the HFrEF. And the vutrisiran in patients with transthyretin amyloidosis and cardiomyopathy in Helios B who had progressed on tafamidis. So we'll look into that. Although we don't have the clinical experience, but we will discuss about this in a short. So let's look at the first thing, the guideline directed medical therapy as fast as possible. The object was to distinguish between simultaneous, rapid, and sequential or slow strategies in the initiation of GDMT for heart failure, and to summarize barrier to GDMT implementation to identify factors that support adoption of the simultaneous strategy. So in this, the study, just one minute. So in this study, the overview it discusses the clinical rationale and implementation challenges of early intensive use of all four foundational heart failure therapy, which we know is ARNI, ACE, ARB, beta blocker, MRA, SGLT2 inhibitors, contrasting it with traditional stepwise approach. Study group was patient with HFrEF, particularly those hospitalized with acute decompensated heart failure or newly diagnosed. An outcome which was studied was mortality reduction, reduction in heart failure, hospitalizations, improved GDMT continuation, and shorter hospital stays. And data were drawn from the registries like ICARA's WTG, heart failure and trials, example, titrate HF. So multiple studies were used. Now, the result was quadruple therapy lead to a 26% absolute risk reduction of all-cause mortality and extends median survival by about 7 to 11 years. Despite 82.2% of patients being eligible for quadruple therapy, only 16% receive it at discharge. I think this is a huge gap between what is possible and what actually happens. Simultaneous GDMT initiation within 48 hours reduces in hospital mortality by 71%. 30-day readmission or mortality by 27%, and mean hospital stay reduces by 2.6 days, which is a very important thing. So we get these mortality where low EF, rejection fraction, suddenly they collapse in ward because of the VTVF. I think initiating as early as possible while they are in the hospital will make a huge difference as we get in this result. So let's look at this slide, which is on the left side, the graph which is on the left side. People who are eligible for quadruple therapy among patients with newly diagnosed HFrEF. So almost 82.2% of the patients are eligible for quadruple therapy. 10.5% would be eligible for the triple therapy. So almost 92% are covered. At least dual therapy can be started in 3.9%, monotherapy in 3.5%, and none in 0.1%, which is unlikely that none of the medications are suiting them. So 4 out of 5 patients are eligible for quadruple therapy at discharge, but only 1 in 6 are prescribed. So this is a good insight as to this happens in our day-to-day practice, and we need to take some step forward towards improving this prescription to our patients. Now, the advantage if we start these early quadruple therapy within 48 hours of ADHF admission, as we discussed earlier, the 27% reduction in the composite 30-day readmission, 71% in hospital mortality. Thus, the repetitions short means hospital stay, and GDMT continuation at discharge is also increased. So the conclusion is quadruple therapy offers the best outcome for HFrEF, significantly reducing mortality and hospitalization. Despite high eligibility, it remains underused. Rapid simultaneous initiation is safe, feasible, and improves long-term outcomes. Adopting this approach should be the clinical priority. I think all of us will agree to this. Now let's look at dispelling the myth. Are HFrEF patients ever stable? So when we say these are patients who have become stable and there are a lot of patients who want to discontinue, so let's look at whether they ever become stable. So the objective was to challenge the common perception that stable patient with HFrEF can reach a stable state and to highlight the persistent clinical risk across all stages of disease, even with optimized GDMT. So this is a case-based evidence-informed presentation combining real-world clinical data, registry, and evidence. It focused on patient with LVF less than 40%. It evaluated, predicted an actual risk of all-cause mortality, cardiovascular death, and hospitalization for heart failure. It tracked changes in LVF, NYHA class, NT-proBNP, GDMT or optimization, and clinical events over the time. Now, result is ongoing risk despite GATMT. So this is very important for all of us to understand. Residual risk remains even with optimized therapy. 15% risk of CV death or hospitalization at 1 year, which was from the PREDICT HF. Prognosis is comparable to cancer. So 5-year survival in HFrEF rivals or worsens that of cancers like colorectal and bladder. So we have to be serious about these patients, even if they are coming to our OPD with, complete symptom free, and they always request for reducing the medications. I think that's not a good idea. GDMT use and limitations, only 41.5% receive full quadruple therapy. High discontinuation rate due to side effect, hypertension, renal issues. I think these were some of the reasons. So despite being eligibility on these patients, a lot of these patients are not on the therapy, and the risk remains, which is very important for all of us to understand. This is the residual risk for patients with HFrEF despite optimized GDMT, and therefore we cannot let loose and allow these patients to reduce their medications. These four pillars have to be continued. So the conclusion was HFrEF patients are never truly stable. Even asymptomatic individuals on optimal GDMT remains at significant risk. And there is an urgent need for more aggressive and sustained GDMT optimization, better adherence and persistent to therapy, timely escalation to advanced therapy when needed. So a myth that patient is stable, now we can reduce some medications because they come with that request. I think it is put to rest, and we should continue to aggressively manage these patients. We have seen that how the risk of 5-year survival is worse than some of the cancers. And therefore, it is our duty to motivate our patient to continue these therapies. Now, let's look at the titration of the ARNIs in acute heart failure. The objective was to evaluate the impact of early initiation and titration of the Saquel versus the ACE-ARB in hospitalized patient with acute heart failure, and to assess whether uptitration of Saquel combination influences clinical outcomes. The design was secondary analysis of Premier trial, which was a multi-center prospective randomized trial. Hospitalized adult with symptomatic acute heart failure from class 2 to 4 and elevated NT-proBNP levels were included. Randomized within 7 days of hospitalization to continue ACE or ARB or switch to Saquel. With uptitration, reached to 50 milligram twice daily by week 8. Without uptitration, stayed on lower dose. So these were the groups, and the outcome: primary 8 weeks change in the NT-proBNP, geometric mean; secondary changes in blood pressure, EGFR, and serum potassium. Result was greater NT-proBNP reduction with Saquel, 51% with uptitration and 39% without, both superior to ACE-ARB, especially in LVF less than 40%. So two things that we have to uptitrate as early as possible. There is a significant advantage, and it is better than ACE inhibitor ARB. Improved kidney function with the ARNI uptitration, EGFR plus 2.72 ml per minute per body surface area. Favorable patient profile in uptitration group: younger, higher BP, more diuretic use, less MRA use, and less atrial fibrillation. Now, the conclusion is early initiation and uptitration of sacubitril/valsartan leads to greater NT-proBNP reduction without increasing risk of adverse effect in acute heart failure. In patients with LVF less than 40%, this sacubitril/valsartan with or without uptitration showed significant clinical benefit compared to ACE-ARB. Even if we don't uptitrate, Saquel is still better than ACE inhibitors or ARBs, and uptitration is better than no uptitrating. So these are the findings, and these findings support Saquel as preferred GDMT strategy in acute heart failure management. It also just emphasizes what we have been doing in our clinical practice, and this is what these studies also shows. Now let's look at the trends in angiotensin receptor neprilysin inhibitor prescribing across all these multi-center, multi-ethnic heart failure population. An objective was to evaluate the prescribing patterns of ARNI therapy in heart failure patient across multiple centers in middle-income countries. Retrospective observational study of ARNI prescribing trend, sample size 416 heart failure clinic patients, hypertension, dyslipidemia, ischemic heart disease, diabetes, CKD. Proportion of patient prescribed ARNI versus non-ARNI, and change in ARNI initiation and dose more than 50% over 180 days. The result was ARNI usage increased over time from baseline to day 180. Finally, the conclusion was that ARNI utilization improved over time but it was initially low compared to other renin-angiotensin system blockers. The study highlights a real-world gap between guideline-recommended therapy and actual clinical practice in a middle-income setting, emphasizes the need for improved implementation strategies to align with clinical trials standards and optimize patient outcomes. The only thing which we can think in our perspective and our scenario is more and more awareness, because heart failure population is huge in our country. And I think more awareness, more this kind of webinars and seminars and physical CMEs, I think that is how we are going to improve and the utilization of these four foundational therapies. Now, angiotensin receptor neprilysin inhibitor in concurrent heart failure with reduced ejection fraction and kidney failure on replacement. So they are on renal replacement therapy. Do these patients benefit when they have CKD and they are end stage and they are on renal replacement therapy? So that was the objective, to evaluate the clinical outcomes of ARNI therapy versus renin-angiotensin system blockers in patient with heart failure and reduced ejection fraction and kidney failure on replacement therapy. The design was retrospective cohort study using the Korean National Health Insurance Service database, compared ARNI users, RAS blocker users. Follow-up duration was median of 19 months and total participants were 4,295. 70% male. All patients had HFrEF and were on renal replacement therapy. Primary composite of all-cause mortality and any hospitalization was studied, and secondary outcome was all-cause mortality, any hospitalization, and CV mortality. The result was primary endpoint reduction. ARNI use was associated with a 14% lower risk versus the RAS blockers. All-cause mortality was reduced by 32%. Any hospitalization was 14%. Cardiovascular mortality reduced by 32%. And benefit across the age, sex, comorbidities, and background medications. Good adherence to ARNI showed benefit. Non-adherence showed no significant risk reduction. So I think the inference is that we can, in patients with HFrEF and kidney failure on replacement therapy, ARNI therapy was associated with significant reduction in all-cause mortality, hospitalization, cardiovascular mortality. And these benefits were especially prominent among adherent patients, supporting the expanded use of ARNI in this high-risk population. So it is safe to use in patients with on renal replacement therapy with additional benefit over the ARPs. So the additional use of sacubitril valsartan in fusion pacing CRT. So in this group, again, the idea was to evaluate the additional value of ARNI in patient receiving LV only fusion pacing cardiac resynchronization therapy, focused on its effect on cardiac remodeling and long-term clinical outcomes. And retrospective cohort studies, 96 with chronic heart failure and LV only CRT indications. ARNI before CRT group 35, control group no ARNI 61 patients. Switch group 48 patients from the control later switched from ACE inhibitor to ARNI, and the outcomes were improvement in LV ejection fraction and change in end-diastolic volume and end-systolic volume, mitral regurgitation grading. So pre-CRT ARNI group, LVF increased from 27 to 39%, 44.6% improvement. And control group, LVF increased from 27 to 27.14 to 30.35, which was 30.5% improvement. Switched subgroup, LVF increased from 35 to 45, which was significant. Mean and diastolic volume and systolic volume were changed with the p-value of 0.04 and 0.027. Mitral regurgitation, significant shift to lower grades. So again, when switched from ACE-ARB to ARNI, again, this group also did well. So the conclusion is addition of the ARNI to LV only fusion pacing CRT provides significant cardiac function improvement as evidenced by increased LVF, reduced EDV and ESV, improved mitral regurgitation grades. These findings suggest substantial additive benefits of ARNI in CRT treated heart failure patients and support its integration into standard care. Now let's look at ARNI and quality of life assessed using the EQ5D3L questionnaire level sum score in patient with heart failure across the spectrum of ejection fraction. And the objective was to evaluate the impact of ARNI on the quality of life in patient with heart failure across the spectrum of ejection fraction, both HFrEF and preserved using the individual level data from the Paradigm heart failure and Paragon heart failure. The design was, it is a retrospective analysis of clinical trial data using Cox proportional hazard models and ordinal logistic regression. Total enrolled were 13,195 patients with baseline LSS data in 12,000, which is 98.3%. And outcomes which were studied were primary time to first heart failure hospitalization or cardiovascular death, and secondary changes in LSS at 8 months classified as improvement, no change, or worsening. So baseline trends, higher EQ5D LSS associated with older age, higher rates of comorbidities, higher NYHA class and lower Kansas City cardiomyopathy questionnaire scores, primary outcome risk reduction with sacubitril valsartan versus RAS, and comparator was in the T1, T2, T3 tertiles, 13% risk reduction, 20% risk reduction, and 30%. And P interaction was 0.49, indicating consistent benefit across all tertiles. So the if you look at the change at 8 months, ARNI increased the odds of LSS improvements and fewer patient worsen and more improved compared to RAS comparator. Conclusion is ARNI significantly improved health-related quality of life and reduced heart failure, elevated events in patient across the full range of LVF. The EQ5D 3LSS is a valuable metric associated with clinical status and outcomes, and it responded positively to treatment. So I think it's all whatever we see in our clinical practice in those patients who are on ARNI and they significantly report improvement in the quality of life. Now let's look at the dapagliflozin for heart failure with reduced ejection fraction, early experience, adherence, impact on patient reported outcomes in evolution heart failure. This is the objective was to evaluate the clinical characteristic, treatment adherence, and patient reported outcomes in real world setting among patients with heart failure with reduced ejection fraction, initiating dapagliflozin and to support its integration into optimized guideline directed medical therapy. This is a multinational observational study assessing early real world experiences with dapagliflozin in HFrEF patients, adult age more than 18 years with HFrEF across 13 European countries. Exclusion criteria was enrollment outside predefined time windows and post dapagliflozin initiation. Dapagliflozin use outside heart failure indications and patient with type 1 diabetes or prior SGLT2 use inhibitor use. Treatment continuation over 12 months. Treatment reported outcomes via KCCQ23, quality of life, and WPAI, productivity and activity, work productivity and activity scores. So more than 90% patient continued dapagliflozin at 12 months. Low discontinuation mainly due to side effects. KCCQ score improved or stayed stable, indicating better quality of life and symptom control. Conclusion was, in a real-world European cohort, dapagliflozin demonstrated high treatment adherence and clinically meaningful improvement in quality of life and work productivity in HFrEF patients. These findings support its use as a core component of optimized GDMT and emphasize the importance of minimizing treatment discontinuation for better outcomes. I think this also is something which we experience in our day-to-day clinical practice. Now let's look at the new and emerging therapies for HFpEF, and I think the slides will be over. So HFpEF masqueraders conditions mimicking HFpEF such as cardiac amyloidosis, sarcoidosis, and hemochromatosis must be excluded for accurate diagnosis. And ESC guidelines, no treatment has conclusively reduced morbidity and mortality in HFpEF. Diuretics manage symptoms, while small studies or rate-limiting calcium channel blockers show improved exercise capacity. The 2023 update emphasizes SGLT2 inhibitor as a key therapy. So this is the change. And I think we all know this is something which came out as a good class indication for all our patients with HFpEF. SGLT2 inhibitors, Emperor Preserve 2021, empagliflozin versus placebo. Patients mean age 72, 45% women, reduced composite cardiovascular death or heart failure hospitalization. Deliver 2022, dapagliflozin versus placebo showed benefit in primary outcomes like CV death or heart failure hospitalization. MRA, the Fine Arts HF 2024, Finrenon in 6001 patient, more selective than steroidal MRA, showing potential benefits. And GLP-1 agonist, where STEP, HFpEF, and STEP, HFpEF DM, where semaglutide in HFpEF patient with obesity and STEP, HFpEF DM included 616 patients, showing improvement in KCCQ CSS. Live GLP-1 agonist has also come up in a big way in a lot of therapies, whether it's obesity, whether it is sleep apneas, and in the Summit 2025, that the tirzepatide in 730 patients, dual primary reduced CV death and worsening heart failure and improved KCCQ CSS. So all these therapies have again shown benefits in patients with the HFpEF, which we all know is a difficult animal to tame, and we are getting more and more these kind of therapies. Then this is the pooled analysis of paradigm heart failure, and the paradigm HF suggests benefit across LVF spectrum through efficacy in HFpEF, though efficacy in HFpEF remains less certain. So HFpEF remains a heterogeneous syndrome with significant diagnostic and management challenges. SGLT2 inhibitors and GLP-1 agonists shows strong evidence for improving outcomes, which we are using. I think GLP-1 receptor agonist will again further come into picture, particularly in HFpEF with obesity and type 2 diabetes. Finerenone and ARNIs offer additional options, though ARNI require further validation in HFpEF. Higher the ejection fraction, lesser was the impact of the ARNIs, but we can always use in patients, if we don't have any other options. Ongoing trials exploring spironolactone, the sotatercept, catheter ablation, and other intervention may further refine treatment strategies. Now, coming to the last part, I think vutrisiran in patients with transthyretin amyloidosis with cardiomyopathy in HELIOS-B who had progressed on tafamidis. I think this is a lesser diagnosed entity and difficult to treat. Again, the objective was to evaluate the effect of vutrisiran on all-cause mortality and cardiovascular events in tafamidis progression. Patient with ATTR-CM who progressed while on tafamidis. So this is a phase 3 international double-blind placebo-controlled trial HELIOS-B with ongoing open-label extension. Total 654 patients, 259 were on baseline tafamidis, 61 identified as tafamidis progressor. They progressed despite the tafamidis. Primary endpoint composite of ACM and recurrent CV events during the double-blind period. Secondary endpoint ACM up to 42 months. So in tafamidis progressor subgroup, 41% reduction in the risk of composite all-cause mortality and CV event with vutrisiran, and 56% reduction in the risk of all-cause mortality. Trend consistent with the overall and monotherapy groups. An adverse event occurred in all tafamidis progressor, but fewer death with vutrisiran versus placebo. No safety concern identified with dual therapy of vutrisiran and tafamidis. I think we don't have the clinical experience, but this is something which was discussed in the latest heart failure summit. And I hope I was a little fast, but I had to complete, and I think we can have the discussion at the end. The vutrisiran showed a favorable trend in reducing the all-cause mortality and recurrent CV events in patients with disease progression under tafamidis and supports potential benefits of switching or combining therapies in tafamidis progressor with ATTR cardiomyopathies. And I would like to end with this. Thank you so much for your patient listening, and I hope I was clear and thank you.
Rahul, that was a great show because you had a very great task of summarizing the entire
Right.
about 8 aspects of ESC heart failure guidelines, and you did a great job. And
Thank you.
each of these points actually needs a discussion. Very nice because it's a real discussion on the Indian context. But as the organizers have designed the study, we'll do it after the second talk.
Right.
together.
Right.
So right away, without much wasting any more time, I invite Dr. Rakesh P. Gopal to go ahead with his talk on the GLS. Go ahead, Rakesh.
Very good evening, everyone. I think I'm audible. I can see you right now. Am I audible?
Yes, sir, you are
Yes,
perfectly
sir.
Yes, you're
audible.
audible.
Okay. Yeah, this is some topic which is very close to my heart since I started working on the strain rate imaging many years ago because we had some issues with patients who had cardiac amyloidosis. So that's how I got into this. So I'm happy to share these slides and the way I understood things. Before starting about strain rate imaging, we need to know there are certain fiber orientation of the heart. The endocardium, you have predominantly fibers which are oriented longitudinally along the long axis of the heart, so-called long axis function of the heart is mediated by these fibers in the endocardium. The mid wall, you have circumferential fibers, which is responsible for the radial shortening. There are no radial fibers. There's only radial shortening, radial thickening, but there are no fibers in the radial direction. They're all circumferential fibers. And the epicardium, we have fibers oriented in a tangential manner at about 60 degrees. They contribute to just circumferential straining, and more than anything else, it leads to twist of the heart. At the base of the heart, it rotates clockwise, and towards the apex, it rotates anti-clockwise. And that is the reason, even when the LV size becomes smaller, the apex beat occurs in the peak of the LV systole. That's because the heart, the LV which is posterior, which comes closer. If you think other way around, the volume of the heart is more during diastole. It should be palpable in diastole. But the fact is that it happens only in systole because of this factor. So this is something, this orientation leads to development of strain, which leads to the cardiac pumping effectively and towards the left ventricular outflow tract rather than within the towards the left atrium and rather than within the heart itself, even if there is some akinetic segment. The subendocardial fibers contributes to longitudinal shortening of the strain. And middle layer, the circular fibers causes radial shortening and which reduce the diameter of the heart and also lead to thickening of the heart. Subepicardial fibers twist the heart, and as I said, if the base rotates clockwise, apex rotates counterclockwise. And this leads to a particular way of contracting of the heart. It's called the descent of the base of the heart during systole. It's an important event. The apex of the heart doesn't move at all. It is the base of the heart which descends, and because of the rotation of the heart, it leads to a kind of wriggling. And then in the diastole, just opposite happens. There's untwisting of the heart, the ascent of the base of the heart, so that the blood which is originally in the left atrium will automatically become within the left ventricle and the right ventricle, similar manner. And the diameter of the heart increases, the radial diameter increases, and there is the atrial systole which forces the blood into the ventricle, both right and left. Here, one thing we should appreciate is that heart doesn't work by every principles of physics. This is because this particular fiber orientation and the way that tension develops within the heart. If it's just a work by pressure difference, left atrial pressure is mere mean of 4 and right atrial pressure will be 2 to 3. And the chamber pressure inside the left ventricle in systole, the peak is at least 100 to 120 millimeters of mercury. So if there's a mitral regurgitation, if everything has to work by pressure principles, the entire blood in the left ventricle should go the moment somebody develops mitral regurgitation into the left atria. It should flood and kill the patient. But it doesn't happen even during severe mitral regurgitation. As much as the LV functions normal, the cardiac output doesn't fall. This fiber orientation and this particular ejection is something very, very important. That's the reason I want to explain to you about the way heart contracts. And the normal shape of the heart is very important in normal contractility and the forward cardiac output of the both left and right ventricle. The ellipse, the apex of the heart has the particular shape and the base has the particular shape. They said the descent of the base is very important. And when the heart starts remodeling, it gets dilated, the apex of the heart is the first to disappear. The base of the heart also becomes in a different shape. Heart becomes more globular. So Laplace's law states that the diameter is directly proportional to the wall tension. The wall tension leads to more preload. So more preload increases the workload. The tired heart finds difficult to pump. And the ejection is not efficacious towards the left ventricular outflow tract. It becomes within the heart. The heart will be pumping within the heart, just like a balloon trying to compress. It can't, it's like a ping pong. It goes up and down. It does not really translate into forward cardiac output. So this wriggling, which happens systole, imagine you're holding the top of the heart, base of the heart with the one hand, and the other hand, you twist the one below, towards apex, you twist anti-clockwise and the base clockwise. This wriggling is very important, and this is the reason why we can never estimate ejection fraction by looking at the heart alone. Because what we see is in a particular window, say apical fourth chamber, that is with a particular window. We are not putting in the probe vertically up and down, past on a short axis. In every window, you can assume to say this, the way it's contracting, and we get a false impression what the actual contractility is. You can get some idea if some of you are doing the old LV angiography, you can see the heart becomes like a sickle with the contrast, when you inject the contrast into the left ventricular. And also, if you are interested, you can always see the MR imaging of the heart. You will get more idea about how the heart contracts and how it becomes difficult to assess the LV function by every means what we have. That is where these things function. Ejection fraction is load dependent and it suffers significant intra-observer variability, not just inter-observer, and does not reflect any intrinsic myocardial contractility. It fails to detect early and subclinical physiological signs of LV dysfunction, especially in heart failure with preserved ejection fraction. It has very limited prognostic value because someone with 38% ejection fraction walk around, someone with 48% cannot do it. So there are a lot of things, loading conditions, PVH, and the LV, EDP, many things. EF measured by his measurement is also affected by reproducibility issues and technical limitations of the imaging, quality, geometry, and whenever you see someone with LVVB, you think the patient is not, the contractility is not good, but when you measure, it's actually normal. I mean, except in acute MI with LVVB, where actually the patient mostly will be in cardiogenic shock. Reliability in terms of prognostication is something very challenging. And spectral tracing macro strain. Spectral tracing basically it states that the acoustic shadows in relation to each other, and then we can do it with the TDI. If you do that, then it has to be along the long axis of the heart, and the acoustic markers are not that well seen if you do only in spectral tracing. But if you do strain rate imaging, measure the end diastolic, reduce the end systolic fiber length from the end diastolic fiber length by spectral tracing, you get a negative value because it is the smaller systole and the larger diastolic dimension. And then you have a lot of ways of looking at it more objectively and more subjectively. So spectral tracing you can do with simple means. Now we have been doing it in almost every patient we want to do echocardiography. That is for our hands to get trained to it. So we basically can even do as short time as 60 to 90 seconds and strain rate imaging. You get to acquire a 4-chamber view, a 2-chamber view, a 3-chamber view, and it is automated. You can see it semi-automated because you have to acquire it properly, make sure all the segments are involved, and then you can look at what the picture looks like. It is better to use this bullseye picture. Here you find something in blue. Actually, it's an artifact. This is something important to read. By repeatedly doing and repeatedly interpreting only, you will be able to make a proper assessment. This particular segment, which is seen here, light red, and red is normal, blue is the least. This is because this particular segment was excluded in the acquisition. So that is something very important. See, it is angle independent and non-Doppler method can be used. You do not use the TDI any longer. Direct determination of the strain without need for temporal integration. Fast imaging acquisition is possible, and it is greatly reproducible irrespective of the operator, and possible to analyze the myocardial deformation in all cardiac chambers, not just ventricles, also in the atria. So there is a significant increase in the usage of spectral tracing, and clinical application with LV-GLS, you can see to detect it an early LV dysfunction. That is where it started applications. But it really didn't translate into the clinical utility because even if you find early LV dysfunction, it does not change the treatment part much. In the cardio-oncology, that was initially when it was introduced, it was a big thing, but it didn't translate into clinical benefits. So for that matter, you need not do it. But it is useful in many circumstances. I'll just show some pictures about it before going to the final presentation list. And GLS also can be used to detect subtle improvement in myocardial function much before the LV ejection fraction improves. LV ejection fraction improves only in about 6 months' time. So if you want to know whether your therapy is effective in the early stages, LV GLS, actually any strain, circumferential, longitudinal, any of this can be used to look at whether your treatment is effective with ARNI or anything. The GLS values will start improving at the end of 1 week and 2 weeks, not in months. So you will have an idea what your patient is going to do. But the real value of the GLS in a patient with a normal ejection fraction is like this. I hope you understand this. This is called cherry on top sign. The red on the central, the strain is reduced all around. This is typical of cardiac amyloidosis. Cardiac amyloidosis is not a rare disease, very common. They have a lot of patients. If you look at somebody breathless and having normal LV ejection fraction, and if you look at the ECG, it will look like something like normal voltage, but the LV will show LVS by echo, and then This particular image is typical of cardiac amyloidosis. This is another patient with hypertrophic cardiomyopathy, non-obstructive good LV systolic function, IVCD, signs of bradycardia, TMT is negative, no known arrhythmias. See this particular strain pattern. Actually, this indicates there is myocardial fibrosis. These white areas are abnormal. LVEF is normal, perfectly normal. This area is abnormal. And cardiac MRI in this patient showed more than 15% myocardial fibrosis. It's an indication for actually the ICD. The beta blockers will not be effective in this patient who have more than 15% involvement. Actually, these are all videos. I can try to play it, but I'm sure it's not going to play in this particular platform. Sorry about that. Still, pictures are good enough. This is something, again, a person with a normal LV ejection fraction, but the strain is abnormal. Especially in the center, the apex, it is lower, white. You all know about the apical ballooning of the myocardium in HCM. This patient clinically, or in echo-wise, does not have a apical ballooning, but the center part of it has started losing strain. This patient is going to have apical ballooning, and the prognosis in such patients are not good. And we will be more watchful in this patient, at least in follow-up and guiding them. And there may be candidates gearing up for something like ICD. No surgery is ever known to improve this, and progressively the cardiac fibrosis increases. Cardiac amyloidosis, again, you can see, or we need not always see the perfect picture of cherry on top. Some strain may be preserved. This is one of our patient who was having an AL amyloidosis. This is a patient who had an acute MI post PCA 1 week. His EF was somewhat something like near normal, 50%. You know why? The strain is reduced in the most central part, the apex, and some only the basal anterior and basal mid segment is involved. You know why this has happened? This much area is involved in loss of strain, but the EF is relatively preserved. This is because the apex of the heart doesn't move during systole. If the base of the heart can descend, it can compensate. That is why the proximal LAD disease, which really mucks up the proximal part of the intraventricular septum and the anterior wall, is called the widowmaker. This patient is a young guy who is possibly using cocaine. He came with chest pain typical of angina lasting 5 minutes, repeatedly 2-3 times. His ECG is perfectly normal, and it is too early to do a cardiac troponin I. And what should I do? Should I take him to the cath lab? But I'm not that justified to take a young man and who actually denies of taking cocaine. He's not supposed to be a smoker. But looking at him, I know he could be addicted to the cocaine or any of the substance abuse. So simply I took him to the echo lab and did this echo. You can see something very clearly, the anterior wall and this inferior septum, it is really loss of strain significantly. I took him to the cath lab. He had a small LAD and a very large circumflex, which is dominant. He required a stent. So if you take this patient to the CT room, you lose time. And if you wait for the troponin I to become positive, again it will take 4 hours. So this is where we have been using GLS in our patients on a day-to-day basis. And this is something interesting. You can see loss of the patchy loss of strain in this areas which is not corresponding to any particular arterial territory. This patchy loss of strain, patchy involvement of the myocardium is typical of myocarditis, especially immune myocarditis in patients who are developing immunotherapy. This sounds an alarm. You have a normal looking LV, normal contractility, but patient is breathless, and this is typical immune myocarditis. We have had one of the largest experience in the world on immune myocarditis patients in recognition and the treatment. And this is what has helped. And this is the beginning of my interest in GLS. You all know about Hirayama disease. It's basically a disease of the cervical spinal cord. There will be asymmetrical wasting of the upper limbs and loss of function. They also are known to cause cardiac dysfunction, typically in this pattern, more towards apex and the base. So cardiac involvement, just a curiosity, I have seen only one patient with Hirayama disease. It was diagnosed by the neurologist, not by me. And then the patient for echo. This is what the finding was. It's something interesting. You should also know how to read that the GLS by repeatedly doing it and assessing it yourself. This is actually an artifact. This particular segment was not coming into the assessment area at any time. Why I know this still if this is an artifact is because I could put this into picture, though the other areas disappear. So the next picture, you can see that actually this area is which is white in color has become red, and the other areas remain somewhat whitish. That's how you know. You can also look at the atrial strain. Atrial strain have the contractile strain, reservoir strain, and you can look at something with more than 40-45% is normal. Maybe that is not part of this talk. SCM with reduced strain in patchy manner. This is a patient who was strange enough to have a normal contractility, breathless, which is proportional to the heart hypertrophic cardiomyopathy. He had a coexisting cardiac amyloidosis. He actually had the multiple myeloma, which was diagnosed for the first time after we did this test. This patient had a combination of SCM with multiple myeloma, and this is how the picture looks like. In both the conditions, cardiac LV ejection fraction was normal. Again, another patient with amyloidosis. This strain rate, we routinely perform GLS in patients who when we do the dobutamine stress echo. This patient at rest, this picture showed low GLS in this segments. You can see this. This is peak exercise, peak infusion, where the strain is normalized in these areas. That means there is hibernating myocardium, which is improved with dobutamine. This patient will benefit out of revascularization. You can also see this area is now blue. You know why? This is an artifact. That is because, again, this could be ischemia. It's developed in the area where there's a stenosis. Why I said it's an artifact is because that particular segment didn't come into the picture, into the acquisition area during when we acquired it. Cardiac amyloidosis, another patient with a similar picture. You can see the LVH. I wish I could show you all the videos of 3 seconds. Now let's come to the topic. The ARNI changed the face of the treatment of the heart failure in the patients with reduced ejection fraction, especially, though it may be used as per the previous speaker in the patients with related preserved ejection fraction. It's relatively, it's a co-crystalline molecule, 1:1 molar ratio, and with a unique properties, dissolution profile, viability, and dissolution rate is faster. It's about 45 minutes. And there's an interesting study by Tiny Nair, and but I'm not going to touch this study because it is not involved in the GLS. That is my topic of today. But the different characters. But they found was that every ARNI was not same. They differ in the dissolution profile, sodium content, and especially also the shelf life. So the innovator molecule, co-crystalline molecule, Azmarda, which is a licensed product from the Novartis, has shown much better stability while stored, while used, and it contains much less sodium content, much better dissolution profile in 45 minutes. It may be more efficacious in the outcomes. And then there's something interesting, as I told you, this strain rate imaging can also be used in patients to see if there's improvement as early as weeks' time than the ejection fraction, which happens over months' time. It's a single investigator study with a crossover. It's a very small study, involved only 12 patients. The GLS alone was the global longitudinal strain was alone the marker, along with TTS, time to peak. From the visit, patients total number of patients 12, 6 randomized to each group. Visit 1, look at the randomization after 4 weeks of follow-up. GLS was done again, and TTP, time to the peak, and adverse events again at 8 weeks. The same thing was repeated, and then patient was crossed over from the generic brand to the innovator brand, and then followed up at 12 weeks and 16 weeks. And a variety of the comorbid factors. And you can see the GLS, change the GLS score from the baseline to 8 weeks was significantly higher in patients in the Azmarda group, 1.7 versus 0.5% in the generic brand. And after the crossover, the reverse happened. 1.4% versus 0.4%. in the Asmada, original Asmada group, now it's generic group. You can see a significant change, and this indicates that the innovator molecule, the Cocker-Slane molecule, the Asmada, led to significantly greater improvements in GLS compared to the generic formulation. And this study establishes the superiority of the Cocker-Slane molecule, the Asmada, manufactured by the original, the innovative the company, or the general formulation, while displaying enhanced LV reverse remodeling in patients with heart failure with reduced ejection fraction, and further highlights the value of GLS as a sensitive and reliable parameter for early detection of left ventricular systolic improvement in the function. And I don't want to repeat it again. Let us stop here for the amount of time. And I think I should hand over the mic because we are running late in time.
Thank you, Dr. Rakesh. Great. Your first sentence of your talk made me so happy when you said that it's a topic very close to your heart.
Yeah.
Because in this world of procedures or interventions, it is rare to find actually the beautiful areas of imaging, and these are all being lost. And their importance is.
I am primarily interventional cardiologist. I do everything.
I know, but still, I'm aware of it. When I saw your profile, that is what I didn't expect, that first sentence. So I thought you were just doing the formality of presenting, but then it is good to end up, and also the examples that you showed show the importance of GLS and their utility in clinical practice. Anyway, we'll come to you later. We'll start some discussion about the first speaker, and then we'll get back to you. So now the presentation of the ESC guidelines was extremely useful, and the most important points that were said were that quadruple therapy has to be started early, and it is useful in all LV ejection fractions in heart failure patients, and particularly whether renal function is good or bad, and whether CRT is implanted or not, in all these things. And this is basic things. And the important thing that has been highlighted and that we need to discuss now is that there's a huge gap between the guidelines and science and the real world practice. And when we talk about the European guidelines of talking that only 60, and you're talking about international data, where only 16% at discharge are getting these drugs. So it is, all these are more relevant in our country, in the sense that side effects, hypotension, and renal issues prevent guideline-directed therapy to be implemented, as has been told in the international data. But in addition, there are two more points in India. One is the patient psychology of taking multiple drugs for a long time with incremental doses, because as the patient becomes better, he expects the doses to reduce, not increase in any disease. And the second thing is the more important, and we need to discuss, is the doctor's hesitation in prescribing. Now, one thing which was not there in these guidelines, was not discussed, we need to discuss, is it is not just the drugs, but the drugs being given in the right dosage at the right time. The optimal dosage is also very important in all this. So anyway, we have a couple of issues that I want the panelists and also the speaker to come forward. And Komal, are all the panelists on board? Please, I request them to put on their images so that we can discuss about, we can give their opinion. See, the first challenge. Oh, thank you. The first challenge in guideline-directed medical therapy in our country is all four drugs. There's a couple of challenges. The first challenge is all four drugs. Many people do not believe in using all four. Within 48 hours, all four drugs are practically used very little in our country. Now, I ask one of the panelists, Dr. Jabir, could you give your opinion on what is the current trend in your perception of all four drugs being really used within 48 hours? And second thing is, what are the challenges you think based on all the factors that I said?
I agree. If you look into the data, published from India, these are all patients. Most of the data published from India, our registries. If you look at the Trivandrum Heart Failure Registry, the Kerala CSI Acute Heart Failure Registry, in the ICC Heart Failure Registry, and the National Heart Failure Registry, all these registries are basically about acute heart failure admissions and discharge medications. So when they look at the discharge medications, 1 in 4, that is 28 to 30% is the use of the guideline recommended medications. And the Trivandrum heart failure registry and all, at that time it was beta blocker and AR, only RAS inhibitors. And the last data which has come up is the National Heart Failure Registry data. There also by that time 4 pillars of therapy have been established, but the use of ARNI was very low. So now it's closed. Whatever data we have right now with us, it shows the usage of guideline recommended medical therapy at the time of discharge is close to 25 to 30%. There may be what I have looked into our own data. Our own data shows that it is close to 60%. The use of SGLT2 inhibitors seems to be quite high. It's around 60 to 70% at the time of discharge. Our data, beta blockers is the highest usage. It's close to 80 to 90%. The least used is, or maybe close to 20-25% only, is the use of RAS inhibitors, especially ARNI. The last data available with us shows ARNI usage is around 4%, but I'm sure that this might have improved over time, and worldwide it is close to around 18-28% use of ARNI. And the latest data available are showing 40 to 60% of usage of ARNI at the time of discharge. The most important obstacles in the usage of guideline recommended medications are: one is the hemodynamic perturbations, the blood pressure, heart rate, the renal dysfunction, the EGFR, and the potassium level, and physician inertia. That is one of the most important things. So these are the 5 obstacles. And in that obstacle, SGLT2 inhibitor seems to be a very, very friendly drug. All over the data, even including the Western data, the last data is the EVALUATE-HF trial and all, they found that SGLT2 inhibitors is the drug which is reaching the target dose, because target dose is the beginning dose. So there is no issue with the target dose and the beginning dose. That is maintained over a longer period of time. But other drugs, there is withdrawal during the course of time, or a reduction in the dosage during the course of time. So these are the obstacles, of which one of the most important obstacle is physician inertia.
Yeah, that you summarized it well. But now let us go into more specifics. You're generally given the broad lines, but look out to specifics. Now, this question of hypotension and all that, I'd like to also bring in Dr. Rautre. What do you think? How much is it real? Like, for example, when we start these drugs, we don't start all 4 drugs. We start 1 or 2, and within 48 hours, 4 drugs is pretty aggressive for any Indian doctor's point of view. Honestly, very few centers do it. Now, how much is a perceived or how much is real? Like, what blood pressure would you be comfortable? 90 blood pressure, would you start these drugs? 100? Or are you afraid if it is 90, it will go further and then restrain? Or do you start Valsartan first and then go on to the ARNI, or directly go into the ARNI? Dr. Rautre, what do you think? I want to be more specific, or as a cardiologist, what are the real things?
Yeah, good evening. This is very important actually. If you look at the data, what Dr. Jobit told, I am in an institution. If institution data like you, that is something different than the what registry data or real world scenario it is there. But here usually we give this percentage of receiving the medications a little high compared to what we find in the general registries. But coming to again specific, for example, I am telling SGLT2 inhibitors, most of the patients are taking SGLT2 inhibitors. And coming to the MRA and or what sort of any ARB, or this thing actually limited because 2 reasons, mainly 2 reasons. One is blood pressure at the time of presentation. Many times blood pressure is around 90 to 100. In such a situation, it is difficult to start such a medication unless the patient is stabilized. You cannot you cannot start. Then second, and renal dysfunction is about 20% of our patients were at the time. If you see, there may be some sort of renal dysfunction. Though we can give these medications, but at the same time they are congested. We'll have to decongest and see the parameters and start. Regarding the beta blockers, though in a longer run, beta blocker most of the people are using, from the very beginning it is difficult because certain other because for this mainly because of hypotension and patient and congested test, unless they are stabilized. So it is difficult to start all 4 medications from the very beginning, though it is advised to start and see in first 48 hours. If you start, then definitely the results are better. And this event reduction, mortality reduction, all these are better. But it's really practically telling, it is very difficult to start. Actually, the percentage of patients starting all for medication is less because of the patient scenario. Maybe I will say in my practice, in what I see, about 20 to 25% where we can low dose all four medication I start and gradually optimize the medications gradually. And Dr. Jabi told one thing is good for SGLT inhibitors, single dose, no need of optimizing, and that's the most tolerable medication if you see. But coming to say most of the patients usually tolerate 2 medications or sometimes 3 medications. But once the patient is stabilized, then you see this blood pressure will improve. Then we can optimize the medication and come to the target dose. It is very difficult in our setting compared to Western population because our population different here. Usually one of the limiting factor, unless the patient is pre-hypertensive earlier, usually blood pressure is very borderline. That is important.
Dr. Haigrave, I would like to make a comment.
Yeah.
When we try to start all the 4 medications as early as possible. On day 1 itself, we start a small dose of beta blocker. We don't consider give too much importance to the pulmonary congestion because many of the older beta blocker trials, they have started beta blocker only once the patient is adequately decongested. We start on day 1 small dose of beta blocker.
Despite pulmonary edema?
Even in pulmonary edema. SGLT2 inhibitors, we start on day 1. If not contraindicated, mineralocorticoid receptor antagonists, we start on day 1. The only problem is with the ARNI. We have to wait for the patient to get stabilized, and I keep 100 as a cutoff. 100 without a rising creatinine, without a rising blood urea, no postural hypotension. Because recently the European Society has published the guidelines of usage of heart failure drugs in patients with hypertension. They use a cutoff that is mostly in the ambulatory patients, ambulatory chronic heart failure patients. They use a cutoff of 80 millimeters of mercury, or the use of or there is organ hyperperfusion. So if there is no signs of organ hyperperfusion, no symptomatic hypotension, no postural hypotension, I am comfortable up to the level of 80 millimeters of mercury for maintenance or continuation of the guideline recommended medical therapy. To initiate, I will consider 100 millimeters of mercury as a cutoff point.
Yeah,
Can I make a point?
There is one thing. It is actually one thing you can start, you can continue if the BP is low, patient is stable, otherwise no complaint. But if the patient blood pressure is 90 to 100, it is difficult to start. As you told, 100 plus, even in that case, very low dose. And I am a little afraid of starting beta blocker if the patient is congested, in my opinion.
No, I think once the urine output is there.
Can I make a point? Can I make a point?
Yes, please, Rakesh. Please, Rakesh. Go ahead.
I am very aggressive in treating heart failure. As Jabi said, we start all these molecules, and even if we start Vericiguat along with that and Corlan along with this. And the BP is actually not a big issue. Thing is, there is a difference between low BP and symptomatic hypertension. As you said, if the walking perfusion is good, BP is not a problem. I have people walking around with BP 70. So if the BP is the problem at all, I'll start them on digoxin and still continue vasodilators. And I'll start ARNI on the day 1 itself. And all patients are discharged. 90% of my patients will go home on day 3 or day 4 with a 200 mg of ARNI BD. This is what we really practice. And even if someone requires inotropes, on inotropes, while patient is on dopamine, dobutamine, or adrenaline, I'll put them on the Corlan and then put on these vasodilators. This is a bridging. You bridge with either digoxin or with an inotrope and use only BP criteria as symptomatic hypertension. And I hardly use diuretic. If somebody is hypovolemic, they will not tolerate vasodilators. So I don't use diuretic. Rather, start patient on vasodilators and the guideline-based drugs, and the BP, as I said, only on a symptomatic basis.
Okay. Now that part is well taken about the blood pressure. We'll summarize the blood pressure saying that we should be more aggressive, and I think you should monitor urine output as a marker of blood pressure, organ perfusion rather than the number alone. may not be always reflective.
Yes,
The
I
second aspect is the creatinine. I like to bring in Dr. Nishant Tyagi. Now, there's always a reluctance on using ARNIs based on creatinine. Now, nephrologists tell me that ARB and are extremely good for patients with renal dysfunction, and they actually are aggressive even for until the GFR falls less than 30. But cardiologists don't do like that. Any creatinine more than 1.2, they are immediately desist from using even ARB. Forget about ARNI. So, Dr. Tyagi, would you just make a comment on what? Yes, please. Komal, you want to say something?
Dr. Tyagi left, some emergency came. So
Okay, that's fine. So,
Can-
would
can I take this question? I have some experience on this. I have some experience on this. ARNI
Go
is,
ahead.
I don't stop in this patient if the creatinine goes up to 1.5 to 1.8. Our nephrologists are very comfortable. If they know hyperkalemia, it's only the creatinine elevation is because of the correction of the volume started with the patient. Patients on ARNI, potassium of 5.5 is acceptable. Potassium 5.5 and creatinine up to 1.9 is acceptable. Definitely up to 1.5. Basically, ARNI is a nephroprotective drug.
Yeah.
Rakesh,
Yeah.
Rakesh, I fully agree with you because we have to be aggressive. And second thing, we have the latest data of ARNI usage in patients on renal replacement
Yes,
therapy.
yes,
There
exactly.
is mortality reduction, the hard endpoint reduction, and life-threatening hyperkalemia was not different between there was no difference between the placebo arm and the ARNI arm. Only thing is very close surveillance on the potassium. That's all.
Correct. Well, I think we should monitor the increment rather than the absolute value.
Absolutely.
That is very well taken.
And try to avoid these patients taking coconut water, lateral powder, and fruit juice.
And the Ayurvedic medications also.
Ayurvedic medication, all these concoctions, they won't even tell you.
Great. Now, the next issue is about the CRT fusion and the drugs. Now, there is not much of discussion except for to make the point that whether you implant a CRT, ICD, or whatever, the guideline-directed medical management should go on with the full doses and full thing, and it is not a alternative. The CRT is not an alternative to that. If you do a optimized CRT like a selective LV pacing, like has been described. Now,
I just wanted to ask you one question. You have put a CRT. It's a hyper responder. The LV ejection fraction has become 65%. There is a new data which quite interesting data. They continued only the carvedilol. Rest of the drugs they discontinued. Then they found that there is no much difference, because I think beta blocker is the cornerstone of therapy in a patient with heart failure and improved ejection fraction. Right now, with the other data available, the TRED-HF and all, I always continue the medications in improved heart failure, complete medications, even though the ejection fraction is 60%.
You have made a very great point, Javier. Now, let me answer it very briefly. In the past, when ejection fraction improved, we used to decrease the number of drugs and keep only the beta blockers. The rest of the drugs we gradually used to reduce and keep on monitoring the blood pressure. Now, after listening to the talk on GLS, I think we should also look at GLS carefully if you monitor it. No, but the point is that we have to go with data, not with our impression. No, the data clearly says what you are doing is correct. Now, what the recommendation now is, irrespective of the improvement in ejection fraction, you have to continue all the drugs, irrespective of the ejection fraction for a long time. But there is value, but you can't just go by guidelines for every patient. Individualized is important. If you are in a center where you can monitor ejection fraction very carefully, and especially with a very monitoring like the GLS and things like that, you are fair enough actually in probably removing one or two drugs of them and continuing the rest of them. But anyway, that is individualized. But the bottom line is that the data says that you have to continue everything.
And I agree. What I would like to put to the common people is that if you are taking off drugs, never take off the beta blocker.
Correct. Totally agree with you, because arrhythmias are always a major concern apart from heart failure. Now, the third thing is, the next point is on.
Say this, like as you said, like if you can monitor, for that you need a team, especially including nurses, communicators, even the dietitians and physician assistants.
I know all this happens in institutional practice, not in private practice.
I'm in private practice. I'm doing it.
Yes. Good.
We have a large team of people to take care of them.
Yeah. No, across the board, there are challenges. Anyway, this is not topic today, but across the board, you may be doing it, but across the board, there are challenges in individual practice. In the West, in Mumbai, one of the, as you know, there are people who go from hospital to hospital. It is not a stable thing to do all these things that easily. Anyway, the next thing is on DAPA. Now, dapagliflozin, great drug. People said they're very, very confident of starting because it doesn't cause hypotension, doesn't cause low in heart rate. But there is one thing which I would like to discuss very quickly because of paucity of time is the genitourinary infections. Now, melanocytitis, these are things which are very, very underreported and under-recognized by cardiologists. They don't really ask, and patients don't think that they should tell their cardiologists because they think that it has nothing to do with heart. Now, there are a lot of patients who have discontinued based on this. And the second point is these days is the concern about combinations. Now, DAPA is being combined with so many drugs. There are even combination with metoprolol also recently. Now, the problem with combination and use of DAPA is when somebody gets these kind of genitourinary issues, now the patient stops that, he stops the combination also. He stops the beta blocker also along with it. So anyway, there are some concerns which are specific to India. Now, I just want to have a quick, anyone could give one comment, if time is there, on the genitourinary infections and DAPA.
Let me make it, sir. Let me make it. Melanocytosis is not a big problem. I said you need to have a team who get checking everything, including the side effects. Melanocytosis, report it. And it is usually, if you can teach them how to keep a proper genital hygiene, melanocytosis is not a major issue in dapagliflozin. 99% of my patients are on steroid inhibitors.
Komal, can we go on for 10 minutes? 10 minutes? Or
And one more thing. Hello, Rakesh?
Yeah.
1 minute.
One more thing I have found out is there are
Let Komal give the green signal. Can we go for 10 minutes, Komal?
Yes, sir. We
Okay,
can.
go ahead, Jabil.
One
10
thing
minutes,
what I
go
found is that it's only during these genitourinary infections that some of our patients find they have phimosis, significant phimosis, and I have seen patients for circumcision after that. It's not because of the drug alone. They have some problem which they have not been disclosing or identifying. And genitourinary hygiene, we have to teach them. Urinary tract infection, a single urinary tract infection is not an indication to stop the drug. But a life-threatening urinary tract infection, upper urinary tract infection, pyelonephritis, urosepsis, recurrent. I fully agree with you. Recurrent urinary tract infection.
See, the thing is, there are cardiologists, they are very aggressive cardiologists who have gone and recommended even without phimosis, they are recommended circumcision.
Circumcision.
To make sure that the DAPA is continued. Because it's so important for the heart failure patient.
Absolutely. Fully agree with you.
Now, coming to your experience, is it more common in patients who are diabetic than non-diabetic?
Absolutely, sir. Without any doubt.
Yes, I find is a non-diabetic usually much less. But diabetic, it appears to be very
high.
Yes, absolutely right. The incidence actually in India is much more reported. No, we're not published, but a preliminary study done informally, this showed as high as 10 to 15% of.
And hygiene is very important. They are not taking care of the hygiene. That's the whole problem.
Yeah, but
exactly.
Cardiologists, cardiologists seldom have the time to explain the genitourinary hygiene to the patient. Honestly speaking.
Yes.
Now, coming to the heart failure with the preserved ejection fraction. Now, just a comment from speakers and panelists of what I'm going to say. Now, after all the data of heart failure, preserved ejection, various things are practically the drugs which work are diuretics and the DAPA or empagliflozin. Actually, these two have been proven to be helpful. Now, rest of the drugs, ARNI.
I disagree with your diuretic comment. Diuretics are not to improve survival. And it
not survival, it's symptoms.
Give one shot when the patient comes acutely breathless. If you depend on diuretics, what is going to happen is you will not be able to give vasodilators.
Correct, but symptomatically, if you don't give diuretics,
first line, I would like to have someone who is little overloaded so that when the intravascular volume vasodilatation occurs, intravascular volume comes relatively less. The fluid will shift, and the patient is with you. You can give a diuretic always as SOS.
Absolutely. That goes without saying. Now, I want your opinion on use of ARNI and Fineron, if anybody has.
Yes, I have been using.
I am also using. ARNI, particularly if the ejection fraction is 40 to 50%, definitely it is working. I will think everybody's experience will be that also. Though the data is not strongly there. Yes.
And also females. That is the data which shows in females. And there are at times you require all the class 2 drugs because drugs are ARNI, as well as MRI, they are all class 2 recommendations, but these class 2 drugs may be required to control the patient. And it's a difficult thing to treat this heart failure and preserved ejection fraction and multiple comorbidities. And I think one thing that we may be soon using much more frequently is the GLP-1 receptor analog, especially in obese patients.
I'm using it in many of my patients already, GLP-1.
Right. I also have started using GLP-1 receptor analog, especially in these patients who are obese.
So basically, in heart failure with preserved ejection fraction, my understanding from the data is that more than the drugs, the addressing the comorbidity is very important. Now, these are obesity, sleep apnea, atrial fibrillation. Another thing, atrial fibrillation can also cause diastolic heart failure. The hypertension, well-controlled hypertension, and iron deficiency anemia.
Yes.
Especially doing the iron profile and correcting the percentage transferrin ratios. All these are very important. They are actually more important than
wish to take IV iron, or who have allergic reaction to IV iron, or who have cost limitations of taking intravenous iron.
Correct.
So there I
these are
stop my sharing and open it for discussion. Dr. Zabir and Dr. Pet. Thank you.
Thank you, Dr.
No, this has to be given in the ICU settings only. This intravenous iron is not to be taken lightly. They have to be taken in an institution. It's always given in the monitoring and in the ICU settings, either ER or the ICU.
Yes, sir. Actually, I'm giving ferric maltose to many of the patients who have low ferritin levels. I have not faced any problem. We are doing it in the procedure room itself.
No, but I think it's not safe. They have been reported. The fatal reactions have been reported.
But not
The last 3 minutes, sir. I'm just last 3 minutes.
Now,
Can we move on?
okay, now we'll stop this heart failure. In the last 3 minutes, we'll talk about GLS. Now, a quick comments on the GLS. Now, a great tool actually. One thing that I would like to add is pacemaker-induced cardiomyopathy. Those patients who are on ventricular pacing, also GLS helps. Apart from oncocardiology, it helps a lot in picking up the early LV dysfunction in patients with who are having pacemakers. Now, one question is, can this anybody can answer? Can this pick up GLS to pick up fibrosis, scars in the LV myocardium, which are indicator of sudden death?
Yes, that's what I showed you about this. The same patient who had a GLS with the apical ballooning and also generalized involvement. And that patient was, after seeing the GLS picture, I took him to the MRI. Cardiac fibrosis more than 15%.
Okay,
very
great.
Good. Very good.
Great. I think we should, that's a great. Anybody want to make a comment on GLS, please? Before time is only 2 minutes. Anybody wants to make a quick comment on GLS?
I would make a comment saying that GLS. Please, all of you, please do it more. Do it in every patient.
Yes, sir. And last questions regarding this innovator.
We have discussed so unfair to GLS.
Yeah, that's the last part. If you can give your views on the last part, sir. The innovator Ernie versus generics. What's your take on that?
There is definitely a difference in the innovator molecule because of its that is the drug which was used in all clinical trials. And the Cox-Lane molecule, that structure is very important. And that can translate into clinical events. That's been, even though the study is very small, it's very interesting that even as early as 2 weeks, you can see the significant benefit in the improvement of GLS, though the ejection fraction per se showed an improvement only in 6 months. So if something is effective as early as the initial days, not just the Cox-Lane molecule, other the molecules too, which are known to improve survival, we have to bang on that. The cost is not the feature that we probably need to discuss. Cost is another issue. What is effective is more the issue. We do never know who can afford what, and for life, people will afford. And that's not the doctor's duty to see how much it costs, how much it works, and that is what we are trained at.
Thanks, sir. Thanks. We will stop here. Dr. Haigreve, sir, can we conclude the meeting, sir? Dr. Haigreve, sir, I think, sir. Dr. Haigreve, sir, if you are there, we will conclude this meet, sir. I think sir has lost the connect. So, yes, sir had joined. Sir had joined. Dr. Haigreve, sir, can you hear us?
No, there's a small disturbance at my end. Battery had gone down.
No issues, sir. Can we end the meeting with your concluding remarks, sir?
Yeah, please. So you discussed about the generic. You just asked about did somebody make?
Yes.
Okay, great. So it's been a great meeting. I thank JB Pharma and also each of the speakers have done a wonderful job, and the panelists have been very active. This interactive session is a lot. It clarified a lot of issues to myself, and I'm sure it will be the same for everybody. And thank everybody for this opportunity. And final conclusion remarks is that we have to start quadruple therapy as soon as possible, and to reach the full dose. Most of the patients with not much care, being scared about blood pressure number and the creatinine number, unless it is rising creatinine or falling blood pressure, and without no end organ down, you would certainly stop all the four to most of the patients. And heart failure projection action, we have to look for trials on ARNI. We are using them. I think we should for more robust data on ARNI and Finerenone, which has not yet come in. And only then we can use guideline therapy. And GLS tool, I'm sure many radiographic centers in the country are not using it. It must be used more often, and to get all the benefits of the early creation in early. With the permission of the son, we'll end this meeting. Thank you very much, everyone.
Thank you, sir. Thanks a lot. So on behalf of JB Pharma, I would like to thank all the experts, cardiologists tonight who have given your expert speech. Thank you, sir. Thanks a lot. Special thanks to Dr. Haigrivara, sir, for the excellent moderation. Thank you, Dr. Gopal, sir, Dr. Rautri, sir, Dr. Jabir, sir, and Dr. Rahul Gupta, sir. Thanks, sir. Good night, sir. Thanks a lot. We're ending. Good night, sir. Thank you, sir.
Thank you so much, everyone. From here, I'm ending this meeting. Thank you.
Thank you, sir. Good night.